And I'm going to talk to you about urinary incontinence, and a lot of what I have to say to you is really coming from the NICE guidelines on urinary incontinence, so you can refer to them at any time after this talk. So first of all, to talk about the condition itself. As you can see, the prevalence of urinary incontinence is a condition that gets worse with age, and women are more likely to have this condition, or it's more prevalent in women than men. But as you see, as you get closer to beyond the age of 70s, they come close together. But it's a common condition, and as women and men, I'll only talk about women, but as women get older, you can see that the prevalence increases, but also the severity of the condition gets worse. So it gets worse and is more common as you get older. If you look at the prevalence of incontinence in different scenarios, you'll see that women living at home, if you're over 65, for example, the prevalence is 10 to 20%. But if you're in an institution, it's far higher. So obviously, people who tend to be in institutions are older and less mobile, and therefore their incontinence problems are exacerbated or exaggerated because they can't make it to the toilet in time as one of the problems. So mobility is an issue, and that would account for why the prevalence is different depending upon where you are. Now, you as GPs are really just seeing the tip of the iceberg, because the number of women that will come to see you obviously increases with age, and you can see from this chart that women are twice as likely, at least across all ages, to come and see you rather than men for incontinence. But because of the fact that it's such an embarrassing condition, women are very reluctant to come and see you and talk about it, especially if they're going to come and see a male GP. I might add that makes it even harder. So it is a problem, and I think understated and underreported generally. So it's a common condition that leads to severe limitation of daily activity and ultimately social isolation. And women who are incontinent, who are having to go to the toilet every 20 minutes, half hour, really become hermits. They stay at home, they don't go out. And I had a patient once who would never have people round to the house for dinner because she was embarrassed that she'd be rushing off to the toilet every 20 minutes or so. And after I dealt with her, she was a totally different person, thank God. So only about 25% of patients with incontinence are known. In fact, as I say, that's very much the tip of the iceberg. And the commonest types are stress and urge incontinence. And the management of this condition does require a multidisciplinary approach. And we've now recognised this, and certainly in my hospital, my NHS hospital at Hillingdon, we actually have an MDT for urogyne patients. So no patients are operated on without having a urogyne discussion, or even the ones that don't need surgery, we discuss them at that level. And the whole purpose of treating such patients is to improve the quality of their life, and it really does make a difference. So the causes of urinary incontinence are obviously genuine stress incontinence, overactive bladder. These are the two main ones, and all the rest are by far less common. Overflow incontinence, and then you can have congenital abnormalities, temporary incontinence due to impaction of feces and drugs, and diverticularly. But the two main ones are the top two. So let's look at some of our definitions, because they do keep changing. Stress urinary incontinence is an involuntary loss of urine on effort or exertion, i.e. coughing and straining or sneezing. Urgency urge incontinence is an involuntary loss of urine which is accompanied or immediately preceded by urgency. So it's a sudden compelling desire to urinate that's difficult to delay. So typically someone, if you get home, you want to go to the toilet, you rush, you get out of the car, you try to put the key in the door, and you want to go to the toilet, and the more you want to go to the toilet, the more you can't fit the key in the door. And that's an example of urgency. And then you can have a mixed picture, and this is quite common, where you have an involuntary loss associated with both urgency and exertion and effort and sneezing and coughing. So you basically have the two conditions, and urinary incontinence with an overactive bladder. And that's quite common. So an overactive bladder is defined as urgency that occurs with or without urgency, and usually with frequency and nocturia. And if it occurs with incontinence, then we refer to it as overactive bladder wet. And if there is no incontinence, then it's overactive bladder dry. Sorry? Sorry, is that all right? Yeah, I just wanted to. Okay. So stress incontinence is a symptom when the patient says to you, they come see you in the surgery and they say, whenever I cough and strain, doctor, I leak. That's the symptom. It's a sign when you demonstrate the leakage. So you get them to stand up with a full bladder, you say cough, and they leak. That's the sign. And the condition is genuine stress incontinence or urinary stress incontinence. So we often use these words interchangeably. So overactive bladder is the other condition affecting up to 10% of women and the second most common cause for incontinence, and it increases with age, as I've already said, and severity as you get older. Urge incontinence is an involuntary loss of urine associated with strong desire to void, and the symptoms are urinary frequency, more than 7 times a day. The average time for voiding is every 3 hours. So if you're voiding less than 3 hourly, then that's abnormal. So that's frequency, more than 7 times a day. Urgency associated with micturition. You get larger amounts of urinary leakage than stress incontinence with urge, and you get recurrent nocturia and recurrent enuresis. Nocturia is getting up at night time. Is that my next slide? No. Nocturia getting up at night time. You're up to the age of 50, you're not supposed to get up at night time at all. From the age of 50 to 60, you're allowed to get up once. 60 to 70 twice, 70 to 80 3 times. All right? So if you get a 60-year-old lady, I'm over 60, so I'm allowed to get up once, which I do, usually just before I'm about to wake up to go to work. So 50 to 60 you're allowed once, 60 to 70 twice. So be careful because, as you get older, the bladder becomes less distensible, more rigid, and therefore holds less urine. And therefore just be aware that sometimes when they say they're getting up at night time, twice in the night time in a 70-year-old, that's normal. Okay? Carry on with the causes of overactive bladder. The commonest is idiopathic, we don't really know. But bladder outlet obstruction, in men, it's the prostate that causes this. But stenosis in women is very uncommon. And then neuropathies, which I won't go into. So the symptoms of frequency and urgency may be present in both the stable and unstable bladder. So you can't tell from the history whether you've got an overactive bladder or urinary incontinence or both. You can't tell. And the reason is because the symptoms overlap. So you'll see here that the incidence of presenting symptoms with an overactive bladder, 90% of women will have frequency, 90% will have nocturia, but 76% of them will have stress incontinence. And if someone comes to you and says to you, I only leak when I cough and strain, and they have none of the other symptoms, there's at least a 10-20% chance they could have an overactive bladder, even though the symptoms suggest that they've got urinary stress incontinence. So the bladder is an unreliable witness, that's what they say. So, as I say, up to 20% of the women with apparent straightforward stress incontinence will have an overactive bladder, and 20% with urge incontinence will have genuine stress incontinence. So the symptoms do not give you the answer. There's an overlap. Frequency of micturition, I said, is daytime voiding, intervals of less than 2 hours. 3 hours is about right. And the normal fluid intake should be between 1.5 and 2 litres a day. A lot of women nowadays they come into the clinic holding a 2-litre bottle of fluid that they've been drinking for the last hour, and then I'll have plenty more as the day goes on. That's abnormal. And I had a lady once who came to see me who had frequency, urgency, and leakage. And what was she drinking? She was drinking 9 litres of fluid per day. And most of the reason for that was because the coffee machine at work was predominantly on her desk. And I asked her to move the coffee machine off of her desk in the office and put it somewhere else, which she did. And when she came back and saw me, she was cured. Amazing. She says, Mr. Nicholas, you're fantastic. I said, I am. So take a good history in terms of fluid intake, because you'd be surprised what women drink, particularly women, because it's in all the girly magazines that fluid is very good for the kidneys, it flushes you out. It certainly does, but it causes other problems. So, you can see here all the other causes of frequency, and a lot of it, you've got to look at habit. Habit is a thing, because a lot of people do like to go to the toilet just in case they get caught, and so they'll nip out to the toilet just before they go out, and then nip out again, when they get to the shopping centre straight away, just in case, and it goes on. So habit is a problem. Going back, beware, and this is where you must always examine them, that a lot of women, I've got a lady at the moment who's got a lot of frequency and urgency, and when I examined her, she's got a big fibroid that's anterior and pressing on her bladder, and that's definitely the cause, well, at least likely to be a cause. So nocturia is a feature of aging. As I say to you, women, little old ladies will get up at night time, but beware that, if you're 70, you're allowed to get up twice at night, so don't go berserk if they say I'm getting up twice at night. But you lose that diurnal regulation of urine as you get older. It's common in the old people. And the other thing is, a lot of these old women who've got heart failure, have got peripheral edema, at night time when they're lying down, their peripheral edema goes into the central compartment, and therefore they have increased fluid in the vascular compartment as such, and they therefore tend to pee more at night time. So that's got to be taken into consideration. They also, as a result of which, suffer with a lot of insomnia because they're up all night, back and forth weeing, either with an irritable bladder, or they have retention, excessive fluid intake, or their drugs. And I think sometimes reviewing their drugs, particularly taking diuretics, they should be avoided towards the latter part of the evening if they can, because if you give them a diuretic at 10 o'clock before they're going to go to bed, they're going to be up all night. So sometimes I've managed to get GPs to rearrange their drug regimes so that they take their diuretic in the daytime. So obviously it's very important to take a history and examine them, and then you try and categorize them. But as I've said, taking a history, you're not going to be right just by taking a history. You categorize them into whether you think they've got urinary incontinence, overactive bladder, or the two. And you treat the predominant symptom. You treat the predominant symptom. So if you think they've got a mixed picture of stress incontinence with an overactive bladder, and they say to me, my main problem is, I do leak, but the main problem is I'm rushing to the toilet all the time, you treat the predominant symptom, which in that case would be the overactive bladder. Okay? So you do that, and if they happen to have a prolapse when you examine them at the same time, then you would consider referral, because the prolapse may be contributing to their urinary symptoms. So a lot of women will have these symptoms without prolapse, but if they've got it with prolapse, then you would consider referral. Give them a fluid chart. That sort of gels their mind as to how much they're drinking. If they need to know, realise that in fact, they're carrying that bottle around with them, but that's the third bottle they're drinking. They've drunk all day, or they're having lots of tea or coffee. Do an MSU. Always do an MSU. Because that is the thing, because a lot of women, especially old ladies with incontinence or symptoms of overactive bladder, have got UTIs. And that is, I've been caught out once or twice where we thought they had an overactive bladder, but in fact they had a UTI. So do an MSU. These other things are obviously done in hospital. So you give them a frequency volume chart where they write down what they drink and how much they pee. And normally when you would void, the amount of voiding that you would do would be about 300 to 350 mils. That's what normal voiding is. So if you see someone who's voiding, 100 mils or 50 mils or whatever, that's not normal. That's urgency. Whereas if someone's voiding 350, that's a normal amount. And it may be that they're just going a lot because they're drinking a lot. We in hospital obviously would do urodynamic studies, and we can tell whether or not we think we can tell whether or not they've got an irritable bladder or whether they've got stress incontinence or both. I won't bore you with that. As I say, always do an MSU, especially in the elderly, and do a dipstick. And basically, if they've got symptoms of a UTI, and regardless of whether the dipstick is positive or negative, send off the MSU, but treat them. Treat them before you get the result. If they've got no symptoms of a UTI, the dipstick is positive, send off an MSU, but wait for the result. And if they don't have symptoms of UTI and the dipstick is negative, then don't send off an MSU and don't treat them with antibiotics. All right? It's obvious. I'm sure you do this all the time. So the rest of this talk now is really more about what's in the NICE guidelines. And I'm just going to run through it. I'm sorry the slides are a bit busy. So when you're choosing drugs for overactive bladder, offer one of the following choices. First, to women with overactive bladder or mixed urinary incontinence. You offer them either oxybutynin immediate release, tolterodine immediate release or darifenacin once daily. And if the first treatment for OAB or mixed UI is not effective or well tolerated because of side effects, offer another drug with the lowest acquisition cost. That's what it says in the NICE guideline. You know more about the cost of drugs than I do, so you will know which is the cheapest. So you work your way down. Offer invasive therapy for OAB and or SUI symptoms only after an MDT review. In other words, that's really when they come to us. So we would then discuss them at an MDT. So the management of overactive bladder is predominantly behavioural changes or sort of lifestyle changes and drugs. Surgery really has a very, very, very sort of low place here, although Botox, if you count that as surgery, is obviously one of the things you can consider. So the lifestyle changes really is to get them to reduce caffeine, because caffeine, as we all know, is a diuretic. Fluid modification, get them to realise how much they're drinking. Advise weight loss, right, especially if their BMI is over 30. And behavioural therapy, obviously bladder training plus or minus anticholinergics for at least 6 weeks in such women. Okay, bladder training. Offer supervised pelvic floor exercises for at least 3 months if they have SUI or mixed symptoms, and they've got to try and contract their pelvic floor 8 times, 3 times a day. So they've got to do that all the time. Get them to stand in front of the sink when they're washing and to contract their pelvic floor continuously. Do not use perineometry or pelvic floor EMG or as biofeedback as a routine part of pelvic muscle floor training. Continue an exercise program if pelvic floor muscle training is beneficial. Do not recommend electrostimulation or PFE unless if they can't contract. Offer bladder training lasting for a minimum of 6 weeks as first-line treatment. This is what the guideline says. So pelvic floor exercises worth trying, and do it for at least 3 months. Absorbent products, handheld urinals, toileting aids should not be considered as a treatment, but only use them as a coping strategy pending definitive treatment, as an adjunct to ongoing therapy or long-term management of UI only after treatment options have been explored. Catheters, sometimes you have to teach patients to deal with intermittent self-catheterization, but do not offer complementary changes. Now, personally, I don't have any objection to it. If someone says they want to go and do some acupuncture or whatever, what's the harm? But NICE says there's no evidence for it, but there's always a placebo effect, especially in urogyne, in the treatment of irritable bladder, overactive bladder. The placebo effect is higher than in most other types of medications, which has been shown in many studies. Do not offer neurostimulation, transcutaneous sacral nerve stimulation, transcutaneous posterior tibial nerve stimulation, percutaneous posterior tibial nerve stimulation, unless it's been discussed at an MDT and drugs haven't worked, and if the woman doesn't want Botox. So you can use percutaneous posterior tibial nerve stimulation, but it's really very much a last resort. And I think now the Bishopswood were about to start doing it. The urologists there want to start using it. It's in the NICE guidelines, and you can use it. I'm not sure how effective it is. Drugs, when offering, and this is the most important one, when offering antimuscarinic drugs to treat OAB, always take account of the woman's coexisting conditions. So if she's got poor bladder emptying and you give her an anticholinergic, you're going to make her bladder emptying even worse. So be careful. Use of other existing medication. So you've got to look at total anticholinergic load, because a lot of other drugs have got anticholinergic activity. Antidepressants may interact. Imipramin's got anticholinergic activity, which you might be giving for depression. I don't know what you use nowadays. But be careful, because your anticholinergic load may be quite significant. And you've got to warn them about the risks. And the biggest risks, as we all know, of anticholinergics is dry mouth, blurred vision, constipation, tachycardia, and those are the main ones. So before you start any patient on any anticholinergic, you've got to go through what the likely risks are of the side effects, which I've just mentioned, constipation, dry mouth. So they need to go through it, go through that with them, discuss the benefits, and they've got to at least try it for 4 weeks. There's no point in trying it for a week and saying, I've got a dry mouth. The worry is that some of these patients who have a dry mouth tend to drink more water. So you've got to say to them, don't drink more water, suck a sweet or something, rather than to drink more water, which only exacerbates the problem. Prescribe the lowest recommended dose when starting any drug. So start low, work your way up if you can, but not all the drugs have got different dosages. Sometimes it's only just the one. If her treatment is effective and tolerated, don't change it. Leave it. Don't change it. Do not use fluvoxate, propantholone and imipramine for the treatment of this condition. So now it's NICE says you shouldn't be using it. I must admit, I used to use imipramine quite a lot for nocturia. I used to give 25 milligrams at night, little old ladies. It's not a lot, I think. And that used to help, but you're not supposed to use it. Do not offer oxybutynin immediate release to frail older women, because some of these anticholinergics do get across the blood-brain barrier, and there's an association with cognitive defects and dementia. So you've got to be careful about how you're going to treat the little old lady that's very frail on other drugs that will perhaps interact with an anticholinergic and whatever. They're quite a difficult group, so be careful in that group. But in the rest of them, offer one of the following: oxybutynin immediate release, tolterodine immediate release, darifenacin once daily. I must admit, I tend not to use darifenacin. I use celifenacin, and I titrate that, but I'm sure you all have your favourites. If the first treatment for OB or mixed UI is not effective or well tolerated, offer another drug with the lowest acquisition cost. That's, again, an economic consideration. Offer a transdermal. The patches are quite good in women who are unable to tolerate oral. I think some women prefer patches anyway, and patch technology is quite good nowadays for all sorts of other conditions. And they say that the patches, the side effect profile, they say is better, but again, it's hit and miss. Of course, if you tried all these things, what do you do? Because anticholinergics are anticholinergics, and they have all got different side effect profiles, or similar side effect profiles to a greater or lesser degree. Then, of course, there's Batmiga, Mirabegron, which if you should consider using if the anticholinergics don't work, if they're contraindicated, if the patient's got side effects from the anticholinergics, and so on. And this is a totally different family of drugs. It's a beta-adrenoreceptor agonist, allows the bladder to relax, fill and store urine, and there are 2 doses, but you start off with 50, you only give 25 if they've got renal or hepatic impairment. The cost is not that great, and in fact, the rate of adverse events using Mirabegron versus tolterodine is the same. But we use it and say this because when they come to sell it to you, the reps say, "Oh, it's the side effect profile is better," but it's not necessarily so. So there's that's useful. It's always good to have another drug to be able to give. When reviewing overactive treatment, drug treatment, offer face-to-face or phone review after 4 weeks. So they must take it for 4 weeks, and if they're better, or if you've made the symptoms better, you may not have cured them, you continue. If they're not, or the side effects are an issue, then you offer something else. And you offer referral if the patient doesn't want a second drug but wants further treatment. Otherwise, you keep them on the medication annually, review it annually or every 6 months if over 65, and refer if not happy. That's my view. This doesn't say that in the guideline, but I would say if you're not happy, you've got to be able to refer. Otherwise, you're stuck with a problem. Desmopressin is useful for nocturia. Use it with caution, and in the old people who've got heart disease or hypertension. Duloxetine was the only drug that came out for urinary stress incontinence, and it's not really recommended. You can use it as a sort of until you get surgery for the condition. So it's not really a drug that you should be using very often. Although it is an antidepressant, isn't it, duloxetine? But although I think you use it at much higher doses. So I suppose you'll make your patient happy if you don't do anything else. Estrogens are useful. You don't give HRT, but you give topical estrogens because estrogen receptors in the bladder and the vagina will be responsive to local estrogens, and they will help. So I would consider that. When do you refer? Well, you refer if you're not successful in the way you're treating them along the lines that we've just said. If the woman wishes to discuss options for further management, then you refer to the hospital, and then the patient will have urodynamic studies and so on. I won't go through that. So you refer if you're worried. Urgently refer women with urinary incontinence who have any of the following: microscopic hematuria. So you'd probably be sending those to urologists rather than gynecologists, I suppose. Visible hematuria, recurrent or persisting UTI associated with hematuria, suspected malignant mass arising from the urinary tract. So these are situations where you would urgently refer, and these are other ones where you would refer if they are appropriate. Invasive procedures, as I say, the one that's commonest is Botox A, not Botox B. It's obviously something that's discussed in the hospital setting and an MDT. It wouldn't be just given like that. Offer it if everything else has failed. If successful, you may need to repeat it 6 months or sooner. Warn the patients of the risks, especially that they may need to self-catheterize. It may not be the answer because they may have problems. You offer it. Otherwise, the other treatments are percutaneous sacral nerve stimulation, augmentation, cystoplasty, or urinary diversion. These are major procedures that you wouldn't go rushing in to do, especially the cystoplasty. Surgical approaches for SUI. If you failed with conservative methods, then you consider a mid-urethral tape. That's a TVT, tension-free vaginal tape, which we've done lots of. I've been warned, I've got 5 minutes. Right, 5 minutes, I finish. So you offer a TVT, cobble suspension, we don't do anymore, and fascial slings. I'm near the end, actually, last 2 or 3 slides. Surgical tapes, TVT, just tell them the success rate is 85 to 90% short term, 60 to 70% long term. Great operation, I've done many, and it works very well, and they're in and out overnight. You can offer them intramural bulking, periurethral Bulkamed, which is just a sort of overnight thing. Periurethral bulking, you just inject the urethra with a bulking agent, and that's very good, especially for the old lady or someone who's had a failed TVT. You can give them a bulking agent as well. So the takeaway points here, finishing off, last 2 slides are, there's a lot that you can do as a GP, but my view is that if you're in any doubt, you should refer. Despite what the NHS CCG says, I don't give a shit really. You need to, we need to sort out the patient. You ring up. You've got relationships with your GPs in your local, consultants in your local hospitals, and what you do is you either email them or call them or whatever the the way is, but you speak to them and get advice or refer. And my advice is to refer to a named consultant, which is, again, it goes against what everyone says. There's no point referring a patient to a colleague and it ends up with the infertility specialist. And then, there's a delay. So try and refer it to the urogynecologist, he or she, whoever they are, which you would find out. So that was my last slide, and thank you very much.